All right, so I get the pleasure of talking to you guys today about interlaminar endoscopic lumbar discectomy, and honestly, it's a great technique, and I think it's one that if you learn the technique, it will help translate and improve your ability to do endoscopic laminectomies and even more targeted decompressions and even cervical foraminotomies. So we'll go over the objectives briefly. We'll talk about surgical indications, go over some technical pearls, setting up the room. I'll go over some case patient selection through case presentation, and then we'll review some outcome data from the ESRG data, which is, as you can see, quite amazing. So I would say first and foremost, surgical indication would be, for central disc herniations, and then, of course, subarticular zone or paracentral disc herniations. And as you get more, facile with using the endoscopic approach and laminar approach, you can then, learn how to do lateral recess decompressions. I would say for the novice endoscopic surgeon, you would start with a L5-S1 disc herniation, and then as you get to become more proficient, you can then go to a L4, L5 level, and depending on the size of the laminar window, you may have to remove a little bit of bone. So typically, just the setup, we kind of went over this, but I like to stand, on the ipsilateral side of the disc herniation, and I like to have the monitor for interlaminar cases actually at the head of the bed, and you want your C-arm to come in away from you, and that's just more so for a better ergonomic kind of setup. And so this is kind of how I have patients positioned on a Wilson frame, and then essentially I like to open the Wilson frame to kind of maximize the laminar window. And then, I have this tower at the head of the bed. This is an example of one of my partners, Dan Hafez, doing a endoscopic discectomy case or transforaminal discectomy. But the whole point, as you can see, the room setup is that there's a tower that's directly at eye height level right across from you. I would recommend using a C-arm and C-armor to help kind of minimize your use of C-arm drapes. And then I think it's important for people who are starting off to understand that the endoscopic instrument is one that you should really learn how to hold and kind of caress to a degree, right? You don't need to have a death grip on it, right? So you can see this as an example, one of our residents, he's got a nice gentle hold of the scope in this vertical kind of access, and he allows it to rest, and he's keeping a little bit of downward pressure on the outer tube just so that we can always control the working tube. And I always tell people to avoid being a statue, because ultimately, at the end of the day, you want to use the 360 degrees of the scope and kind of move your body ergonomically so that you can achieve the visualization as best as possible. And then, so now let's go over a couple of, cases, and that will help kind of identify, how I pick patients. And I would also like to give a shout out to the ESRG group, as everyone has done here already. And you can see that we like to collect data and talk about our cases, because we're all nerds about endoscopic spine surgery. So this is a patient, 74-year-old male. They had radiculopathy with a right paracentral disc herniation. And just to highlight kind of the way that I like for you guys to work through this is the preoperative images that are directly from the app itself. And then you can see here, this patient had about 90% app engagement, which means that they actually answered about 90% of the proms. And then you can see here, this patient reported essentially 100% pain relief, and that happened around the 2-week mark. And then over on this one, this is directly from the app. You can see patients returning to work. Well, he's retired. He didn't use any opiate pain medications. His activity goal was achieved in 1 day after surgery, and this was his feedback from the app. So as we move through these cases, you can see this and kind of evaluate on your own. Well, this is a patient who was a 49-year-old female who presented with a cauda equina symptom. And it was kind of unfortunate this patient had presented to an outside hospital, but because of her weight, they didn't offer her surgery. They essentially said follow up with, institution that can, do surgery minimally invasively. And so I did this patient's surgery. She had, 100% app engagement. I was extremely happy. And you can see that this patient had significant pain relief almost immediately after surgery. You can see that she had back pain, not a lot of leg pain, but surprisingly, by day 1, the back pain started to come down. She's 3 months out, and she's doing quite well. You can also see how much she's walking. I love my iPhone user patience. This was her post-operative imaging, kind of showing that we resected that disc fragment and decompressed the canal. And then we'll just move on to the next patient. So 57-year-old male who had a radiculopathy. You can see there's a right paracentral disc herniation. Surprisingly, men tend to have a lot more pain than our female patients, but you can see his back pain was severe, and his right leg pain was also severe. Just to contrast, this patient who had this massive disc herniation where you could barely see the thecal sac, she just said, oh, a little bit of back pain, a little bit of leg pain, but I'm okay. So anyway, but just moving on, you can see that, this gentleman, let's go back to him, his pain got better almost, day one from surgery. Back pain took about 2 weeks. And, again, not a lot of stepping down from this patient, which I kind of think ties into, kind of patients who have, these disc herniation, these back pain problems, because they don't have really a great active lifestyle. But that's another thing we could look into. This is a 39-year-old female who had mostly lateral recess stenosis and a little bit of a central disc herniation. And you can see for this patient, again, more of the same common trend, some improvement in her actual activity after surgery. And I think this patient's 6 months out and, maybe a little bit of flare up and back pain, but not much compared to what it was before surgery. This is a 28-year-old female with, again, large right paracentral disc herniation with a little bit of extrusion and very small caudal migration. And this patient had severe right leg pain that took about 2 weeks for it to improve. And, I think that a lot of these patients who have these massive disc herniations, you go and you resect the disc, some of them will do extremely well the day after surgery, and others take a little bit longer. But the trend that I'm seeing is that sometimes these patients have stretch injury, so maybe I'm a little bit aggressive with my, discectomy, or maybe that pain that they had sat there for too long. Either way, a recovery at around 2 weeks, I think, is a quite impressive improvement for this patient, to the point where at 1 month, when her pain finally went away, she started to see significant improvement in her ambulation and her walking. So, maybe a point for a surgeon, for learning, but I think it's interesting to see these patient outcomes and actually be able to evaluate them in that first 2 week period. Whereas with most patients, you don't see them until they're doing great already at 6 weeks.
John, I think one of the benefits of endoscopy, and especially the interlaminar approach here, is how easy it is to work in the axilla between the thecal sac and the traversing nerve root. And these kind of cases in particular are, I think, particularly amenable to that, because you can see that traversing nerve root really being plastered laterally. And in these, I typically just plan to work primarily through the axilla, at least to debulk that until you can mobilize the traversing nerve root and get it over, and which is not something I would feel comfortable doing through a tube or open or anything like that.
So you can do a little more shallow approach angle, so have your incision a little bit lower so that the axilla is bigger. So I think we've done that. So.
Yeah. And honestly, I think I'm being really critical, and I think that's the whole point of this data, right? Is if I, did this case and sent the patient home, day one from surgery, she's doing great, and she never had this app, I probably would have never known that she had a pretty tough recovery. So this is more so me as a surgeon looking back and saying, how can I improve my surgical outcomes? So this is another case of a patient, 48-year-old male, who had a little disc extrusion with caudal migration, and I think you guys are starting to see a trend of my practice. And again, this patient, was very active before surgery, but again, extremely active after surgery. And I think this kind of points out and highlights the benefit of endoscopic spine surgery, where patients get literally day one, he took a little nap from the anesthesia maybe, and day two, he went back to the races. And for these patients, they have significant improvement in their quality of life a lot sooner. So, and this is just really the trend that I'm seeing. This is a 30.
Hey, John, I love that you're showing some of these cases that look like cauda equina-like. Because number one, there's always been that knock. Minimally invasive is not appropriate for cauda equina.
Yeah.
And most of the people in this room would disagree with that because you're going smaller, you are safer because you're really putting less stress on the nerve roots. So in some respects, but that would be a lively debate in other circles with a broader audience. So just but I think most of us are comfortable with the cauda equina. And number two is that you're showing that you have big broad bit discs and you're going interlaminar, which means the choice is oftentimes yours, right?
Yeah, absolutely.
You can go interlaminar for this because she has stenosis too.
Well, you can see the facet joints, right? And I didn't necessarily want to just simply do transfemoral and miss any disc. I actually wanted to get over, I think I did this from the right side, if I'm not mistaken. And I essentially just swept the nerves over, the nerve over and pulled out the disc fragment. And there was a little bit of a caudal migration where sometimes when there's a caudal migration, it's hard to, especially in a large disc fragment that's that huge, to get all of that fragment out. And then also this patient was a little bit larger, so it was harder for me to kind of assume that I'd be able to, get all that fragment from a transfemoral approach.
I think it's also important to mention that you see how the traversing nerve root is kind of curving underneath the herniation on the right side. Sometimes if you ream in the situation, you can actually just get a big dural tear right there. So I think for the people who are new and trying to pick this up, you can't always utilize both approaches. I think you have to be careful when that traversing nerve root is pinched out a little bit, almost into the beginning of the frame and from medial lateral. So, but I would do interlaminar on this one too.
Yeah, and I think, to Mark's comment earlier, is a lot of these patients who are seeing me with these massive disc herniations, they're coming through outpatient clinic, and it's surprising me to that, someone saw this, got the MRI at some point in time and said, go and see a neurosurgeon. So this was not like an urgent, emergent referral. This was like, see the neurosurgeon in the next available appointment. And, for me, this was, okay, we need to get you in surgery sooner rather than later. And I think the timing of it, the ability to say that for the patient that is a little bit larger, what is the best option for you surgically? Can I do something with a tube? Sure. But look at those facet joints. I mean, if I start to take off too much of that, and this is a large BMI patient, now I'm potentially creating some iatrogenic instability further down the line. So this one is a patient, 32-year-old female with radiculopathy at L5S1, paracentral on the left side. You can see the traversing nerve is actually being tented up against the actual facet joint. And, again, more of the same interlaminar approach, and patient did well. I mean, you see the trend. I think this one is one that I kind of wanted to talk and show a little bit more. This was a 35-year-old female, again, cauda equina syndrome. Patient was at the ER, and they said, well, you have really not significant amount of lack of bowel or bladder, issues, but you should see a neurosurgeon talk about surgery. And so this patient comes to see me in clinic, referred to me from one of the community neurosurgeons because they knew I do endoscopic. His biggest concern was, you can see that there's some caudal migration behind the sacrum, the dorsal ala of the sacrum, or lamina of the sacrum, and it's gone down now, it's entangled in the nerve roots. And you can see this is another image further down in the sacrum, almost a level of S2. So, for a person doing this case tubular, that's a pretty long reach for a tubular approach and a microscope. So we did this case endoscopically interlaminar. We're able to get all the fragment out, and we'll actually show a little bit of the video after. But you can see that this patient had some significant improvement in that pain in the leg, but a little bit of continued dysesthesias, and I think that's more so just from the fact that she had this long-standing problem for a next available appointment. But what we do see is that the patient is moving a lot more than she was immediately before surgery, which commonly, I think, when it comes to this patient's presentation, was maybe a little bit underhandled or mishandled by the initial ER physician, but that's another conversation. So when it comes to how she did, well, she did great from the terms of surgery because we got all the fragment out. And for her, this is a post-op MRI. Oh, I don't think I put it up. Maybe not. Well, next time. So the next one is a 37-year-old male who had a large disc fragment, again, seen in clinic, and he was probably one of my most active patients. You can see that after surgery, he had significant reduction in his pain. 1 year out, he's doing quite well, and again, app engagement is 100%. And it's surprising to see patients who are doing so well still want to continue to engage with their surgeon. And then this is a final case in presentation. This was a revision case for a patient who had a previous L5S1 LAMI. She had a central disc herniation, which was a reherniation for her probably about 4 or 5 years after her initial surgery. And for her, mostly right leg pain, but some back pain as well. And I always ask, other surgeons and other patients, when you have surgery, right, you can have this, right, or you can have this. And I think that kind of demonstrates the less invasiveness of the surgery. So what does the data show? And I think this is very important, again, collected through the ESRG research group. And this is a distribution of our patient demographics. As you can see, about 196 patients were kind of included in this review of data. About 50-50 male and female, average age about 45. The BMI was around 28, so a little bit under 30. And then number of levels treated was predominantly one level and an average time of a little bit over 1 hour. And as we look at the actual information, we can see that most patients have significant reduction in their pain and ODI. Their ODI score drops immediately after surgery, and that was found to be statistically significant. And then from there, there's a 2-week period where they kind of have more so maybe inflammation and proliferation, and they tend to have, some lingering pain, which I think is also a target for maybe treatment with maybe NSAIDs or maybe even steroids. And then again, you see another drop off in their pain during this remodeling phase of wound healing. And by 6 months, patients have had, again, a statistically significant drop in their disability. I think the reason why we see a little bit of an increase at 1 year versus 2 years is that the 2 years, we didn't have that much data to kind of evaluate. I think it was only a few patients had 2-year data. So we look at the actual VAS back pain and leg pain scores as well. And again, you see statistically significant drop in patients' back pain and leg pain. And again, that's just from that surgical intervention. So you provide surgery, their pain gets better. You see that pain kind of lingers on at a little bit of a plateau for about 2 weeks. And then usually by the 2-week to 3 month, 6 month mark, that pain starts to significantly drop almost to zero. And then I thought it was really interesting to look at the stepping data. Oh, sorry, before I get to stepping, we'll go over the pain medication. So you can see patients before surgery, about 30 patients in this group were actually taking pain medications chronically. Immediately after surgery, that number dropped to 9, but then again, that number increased to 72 day 1 from surgery. So that to me says patients started having pain from surgery, probably in that same inflammatory and proliferation phase, and then you see a significant drop in that pain in that 1 month to 3 month and even up to 6 month mark. But most patients by 6 months aren't taking any pain medication. So at most, out of 196 patients, 72 of them needed pain medication immediately after surgery, so less than half. And now we get to the cool stepping data from our iPhone user patients. And you can see that at 1 year before surgery, patients are walking roughly on average about 5,000 steps a day. And as they get closer to their day of surgery, as their pain gets further and further, progressed and gets worse and worse, these patients tend to walk less. And then we provide an intervention, and within that first 6 weeks, their pain improves, and therefore their walking goes back to closer to that 5,000 steps on average. And then you can see that by the time they get to the 1 year mark, our very active user patients tend to walk even more than they were before surgery. So these are, objective data that we can look into further and see how we can, maximize and identify which patients are not doing so well as far as walking versus those who are. And then for the interest of time, I'll kind of breeze through this because we'll go over this in the lab tomorrow. So when it comes to targeting, really you want to get true apial lateral X-rays through the disc space to first kind of identify the disc space, but then also you're going to change the angle of your C-arm so that you can maximize the interlaminar window. As you can see, that interlaminar window size is pretty large at L5S1, and as you go up to L4, L5 and higher, it starts to get smaller. So you want to be able to maximize the approach, and I would say probably 4 or 5 is the limit for a non-bony removal kind of interlaminar discectomy. And then, of course, you don't want to plunge. That can cause an injury. So some people like to, land directly on the ligaments and flavum. I personally like to start on the SAP and then wand down to the ligaments and flavum, and then fill the ligaments and flavum, give it a little bit, and then you know where you are. And then you always want to confirm your surgical level. So for targeting, you want to hit the bullseye. This is a good starting point to kind of for a true interlaminar for paracentral disc herniation. Depending on how large the disc herniation is, you can probably start a little bit more lateral and work your way medial. If it's a central disc herniation or if it's a paracentral disc herniation, you probably want to start more medial and work your way laterally to get to the lateral edge of the traversing nerve. This is just an example of that targeting. We'll kind of move through that. And this is actually that case of that patient that had the cauda equina syndrome. And I promise you I would show you kind of the cool the Interlaminar video from the surgery. And this is, of course, abbreviated. We land on the ligamentum flavum. We make an opening in the ligamentum flavum. Then we use kerastins to widen that ligamentum flavum just so that we can get in our instruments. And you can see that disc was under quite a bit of pressure with just opening ligamentum flavum and even using the tubular retractor just to open the ligamentum flavum without putting any significant downward pressure. That disc just really delivered itself. Yeah.
Come to Papa.
And all I'm doing really is just twisting the scope. Yeah. And so the reason why I think it was able to be delivered so easily is because we targeted the maximum part of that disc that was in the actual axilla. And then, of course, you know, being able to land there and open right above that disc, and then also going back and finding leftover fragments. But the targeting was important, but also the disc was probably under a significant amount of pressure. And that's that patient there. So staying out of trouble, of course, always visualize the tips of your instrument. You want to start, get as far lateral as possible so you can find that traversing nerve root and then mobilize it medial. Before you mobilize the traversing nerve root, you want to be able to actually get to the lateral recess, separate that nerve off of any adhesions or even suspensory ligaments. And then, of course, you can use your tubular retractor depending on how much you're able to mobilize that nerve root. Case in point, and probably why that patient had a little bit of dysesthesias. But you can see that, you know, surgery is not about being fast, it's about being efficient. And if you're constantly practicing these routines and doing the same techniques over and over and focusing on being efficient in surgery, your operative times will get better, as Christoph showed with his presentation in the last slide. So with that, just some closing remarks. I want to say big thanks to my research fellow who actually helped put together a lot of this data and analyze it, and then to my team at WashU who allows me to do the endoscopic spine surgery while they take more of these bigger complex cases. But I do think that it's a team effort and you have to have the support of your institution. And then, of course, any questions? ESRG, thank you for data. And any questions?
John, thank you. That was a great talk.